I'm I'm the I'm a family doc, primary care guy, a public health guy, um, and a writer, and the president of Primary Care for All Americans. Welcome, and thank you for joining us. Thank you for joining people from now more than 40 states in the District of Columbia and 300 plus zip codes who are building this movement together. I spend a fair amount of my time now thinking about primary care and thinking about the really significant crisis we face, um, not just about primary care, but about health workforce in general, but about the huge challenge that we really have when we think about the access to primary care that the nation has provided and how much trouble we've gotten in by not providing that access. And that trouble is that when there aren't enough folks doing primary care, and the best numbers suggest that less than 43% of American adults have a longitudinal primary care relationship. When those numbers are so small, that shifts people to the emergency department, to specialists, and to sitting at home and not acting on things that they've noticed that actually represent preventable disease. So we've got a public health crisis as a result. We've got a cost crisis because when people go to emergency departments and when people get admitted to the hospital inappropriately, that allows the folks with something to sell to spend a whole lot more money or to bill a whole lot more money, collect a whole lot more money, and take that money and use it to enrich themselves and also to lobby Congress and state governments to keep things as they are instead of giving us the healthcare system that's for people, not for profit, that all of us need. I've listened to the high level bureaucrats, the politicians, and the money guys in healthcare for 40 years. I've sort of been at those tables. And I know from listening that it turns out there really is no one in charge. I know that the cavalry just isn't coming, and there's nobody but us left to fix it. I'm thrilled that we're going to hear tonight from Michelle Cooke, a dedicated primary care physician, healthcare optimist, and a powerful speaker committed to revolutionizing healthcare, something that we all need to do together. So please listen to Michelle. Stay on at the end while our board joins Michelle for questions and discussion. We'll be talking about how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for this evening, Patty Armstrong, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom, all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Patty.
Hi, everyone. I'm Patty, and I want to thank you all for being here tonight. Being here makes you a part of this movement as we learn together the tools we need to break the stranglehold so we can provide healthcare for people and not for profit in every neighborhood and community. Primary care for all Americans. Please take a second, if you haven't already, to write in where you're from into the chat. We're building a movement here, and we want to see where that movement is happening and how do we work together and get to know each other a little bit more. So to make this movement rock and roll, we've implemented a new policy. Hopefully you're used to it by this point in time. I know I'm still getting used to it, but we really want to focus on culture, tolerance, and respect, working together to reach these new ideas, bringing together unique talents and everyone equally. So, no professional titles, please. Let's talk about the importance of what we're trying to do, engage in the work, and value everyone's ideas and commitments, which is what will build this movement at the end of the day. It is my pleasure to introduce tonight's speaker. Michelle has been wonderful to get to know. You can tell from when she talks how passionate she is about primary care. She is, as we say, an optimist about what can happen and what we can do by coming together. And she is a powerful speaker committed to revolutionizing healthcare. She is recognized as a top doctor by Atlanta Magazine and Castle Connolly. Dr. Cooke is deeply invested in her patients' health outcomes and the broader community. She speaks nationally to physicians about the importance of direct primary care, also known as DPC, with a mission to bring as many physicians as possible into DPC models, a perspective of lifestyle medicine, helping patients achieve optimal health through healthy behavior modification before medication. She is particularly interested in women's health, obesity, metabolic disease, and care for the Black community. For tonight, we are here to both teach and learn from one another. We encourage you to ask questions. Put them in the chat. We'll have time at the end of Michelle's presentation to talk through some of these different questions that we have. We'll try to end our formal program right at 9 p.m. Eastern Standard Time or 6 p.m. Pacific Time. But we will invite everyone to stay on for an interactive half hour at the end till 9:30 or 6:30 as we work together to discuss, plot, and plan. Well, now I'm very pleased to introduce our keynote speaker tonight, Michelle Cooke.
Thank you so much, Patty. That's an incredible introduction. I got excited, like, oh, speaking tonight. Sounds like fun. I'm so honored to be here. And I think one of the real treats is I got a chance to meet Michael Fine. I didn't realize I was going to meet him before this meeting, but as he mentioned at the Rosetta Fest, we got a chance to connect. And we don't know each other very well, but I can tell we're just very passionate and committed to the same thing. So I think I can get away with saying some of the things I'm about to say. Michael Fine is a bit senior than me, but what I will say is that his passion, and at his age, which I'm not sure what it is, to want to start a social movement is just so inspiring. As a physician, there's so much apathy, there's so much burnout, and it's just the idea to just want to throw in the towel. A lot of physicians I talk to are dreaming of other careers and dreaming of other things to do besides medicine because we're so burned out by it. But to meet someone like Dr. Michael Fines and saying, let's take to the streets, no one's in charge, the cavalry's not coming, we can do this together, is just, it's amazing. So I'm very happy to be here. I am in the city of Atlanta. I'm in Atlanta, Georgia, although I'm originally from Boston, Massachusetts. I did see a lot of you from, or not a lot, but a handful of people mentioning that they're from Massachusetts. And I know that Michael Fine is from Rhode Island and several folks coming from Rhode Island. And I think it's important to talk about the true state of us being in a healthcare crisis. And I mentioned where I'm from because in Atlanta, as much as I really enjoy being in the South unfortunately trails in almost everything that should be positive. And that's true for healthcare as well. So we're always behind the 8 ball. My parents are aging and they still live in the greater Boston area. And I've always wanted to move them closer to me as they're going into their senior years. But one reason I've always wanted them to stay in Massachusetts is I was like, you all have some of the best healthcare up there. Don't leave. You don't want to come down here because there's terrible things happening. What you'll hear in my story is that part of what propelled me into direct primary care is that part of the hospital systems in my area, in my community, closed. And so options were slim. And so I had to take action. And my parents watched that and couldn't believe it. But if you all are in the Northeast or in Boston, you know exactly what's been happening with the Steward healthcare system. I didn't believe that many hospitals would be at jeopardy of closing. And I think they saved, you guys can correct me, but I think 7 out of 9, but 2 major hospitals serving underserved communities gone. My mother, who used to be able to get better access to her primary care doctor, struggles to get an appointment. I think last year they mentioned that Boston Medical Center was no longer accepting primary care patients because they didn't have capacity. And so to me, if Boston is falling, we are all in trouble. And we're so far beyond this being a crisis. Like, this is beyond crisis level event. So I hate to start that way, but I think it's important to talk about what we're dealing with. And I want to talk about the healthcare experience from the perspective of a new direct primary care doctor. Patients, I think, experience a terrible time in healthcare right now. It's really hard to get high quality primary care unless you're seeing direct primary care. And I want to talk about how direct primary care plays into this plan to be able to get primary care for all Americans. But the reality of what's happening is that patients are waiting longer to get appointments. They're paying more to get access to appointments, and they are not getting the quality care that they deserve. A lot of times they go in and FaceTime with the physician might be 7 to 15 minutes, which if you do anything in life, it's hard to do anything meaningful in that period of time, let alone deal with a complicated medical condition. What bothers me is that a lot of times patients feel like it's the doctors that are doing this, that, oh, these doctors don't care. They don't want to spend time with their patients and they're so greedy. And that may have been true at one point when doctors were at the helm, but that is no longer true. We have flipped from doctors having or being the primary owners of medical practices to now more than 70% of doctors being employed, which means that all of us have a boss that we report to and don't get to make the final straw about patient care. And that is inherently dangerous. So when I came out of medical school and I came out of residency, years ago, they may have said, now it's time to go out and hang your shingle and start your practice and serve your community. But now we're saying, no, go and find a good contract and go work for somebody. And that's not a bad thing to do. But in healthcare, I think it can present some inherent problems. Some of the problems are, again, the buck doesn't stop with you with regard to patient care. So even though I was a physician in a healthcare system, when I said I need more time with my patients, I have someone coming in who's suicidal. I have someone coming in who has a new cancer diagnosis that we have to discuss. My follow-up appointments were 15 minutes no matter what. And I had no control over that. So it was very common for my schedule to be packed 20, 25 patients throughout the day. And if you all have ever talked with somebody who just found out they had cancer or who thought about taking their lives, that's probably going to be the heaviest conversation you've had that day. Imagine doing that 15, 20, 25 times. It's unsustainable. And we are prepared to have the hard conversations with our patients. We're not prepared to do it at that pace on top of all the other administrative burden that we have to face as physicians. So there's portal messages that come in, there's refills that come in, there's sick visits that still need to be seen that day. And so the job is literally impossible. There was a great study that came out that said that primary care doctors need 26 hours per day in order to do their job effectively. And when I was still in employed practice, I was like, you know what? This article has come out. We now have evidence and proof that what we're doing is impossible. And I thought that there was going to be change that happened, but nobody seemed to care. And so it proved what I was feeling, that what I was doing was just not possible and not sustainable. And if you're trying to do it, you're going to fall short every day. And when you do a job where you're falling short every day despite your best efforts, it is a quick recipe for burnout. So whereas patients see a lot of physicians as part of the problem, a lot of the physicians are also victims in the system too. Not only have we agreed to be employed and not be able to make the rules, we're stuck to these guidelines and these policies that are really very rigid and don't allow us to be the best doctors that we can be. So did we sign up for it? Yes, and that's part of the problem. There are other pressures. As most of us know, the cost of everything has risen. And one of the things that has risen astronomically is the price of medical school. So many of us are graduating with really 2 homes worth of debt that we need to pay off almost immediately to make it worth it. And so being able to accept a position seems like the best way to be able to get yourself out of really what could be financial ruin. So a lot of doctors feel like they have their hands tied. In the background, we have these insurance companies, which right now everything is crumbling in healthcare. In my community, we've lost multiple hospitals. We saw what's happened in the Massachusetts area. I think over 500 hospitals are at risk of closure across the country. And the only people doing well right now are these large insurance companies. The dollars are in the system, but they're flowing the wrong direction. So I say all of that to lead to my point of where does direct primary care play into the picture? Direct primary care is a form of, it is primary care. It's really just that, it's primary care. But direct means that the patient contracts directly with their physician rather than using the intermediary of insurance. So I think we have made insurance too big. And I think insurance, in my opinion, as a direct primary care doctor, is incredibly appropriate, especially in the primary care space. Insurance is meant to help protect us from the catastrophic and the abnormal, but there's nothing abnormal or catastrophic about primary care. When you're creating an insurance pool, if you're getting flood insurance or fire insurance, the only reason it works is because you don't expect everybody in that pool to have an event. But when you're pulling everybody together that needs to have something happen every year, or maybe multiple times a year, we need to have a physical, we need to have our mammograms, we need to have our vaccines. When you have to cover all these things, it's no longer insurance, it's really prepaid healthcare. And that's where the price incentives and the or just get very misaligned, and the cost can go up astronomically. So I think using insurance as a mechanism to pay for care is hurting us all, or at least to pay for primary care, which is something that's not astronomical or extraordinary. It might make sense for the extraordinary if you're getting surgery or getting hospitalized. Hopefully, most of us don't need that to happen multiple times in our lives, but we all need primary care. So I think that's part of how we got into this mess. So when we remove insurance from the primary care relationship, we call that direct primary care. So there's nothing different about the doctors or nothing different about, the way that we practice. It's not a practice style. It's really a change in the payment model. And what direct primary care does is it does so much. I really can't even begin to talk about the benefits, but it gets the elephant out of the room that really stopped me from being able to serve my patients the way they needed to be served. So in direct primary care, many physicians are starting these practices, so it puts them back in the driver's seat to make the best decisions on behalf of their patient and their community. How you take care of a patient here in Atlanta, Georgia is very different from how I would take care of patients if I still lived in Boston. And so those physicians need to be able to make that decision. But if you have these large healthcare conglomerates that treats a patient in Oregon like they treat a patient in Alabama, it just doesn't work. Healthcare has to have a local component. The second thing I think it really helps keep doctors in the community. I started this practice. I can't just pick up and leave it very easily. But I think doctors have become like NFL or NBA players, and we'll follow the best contract. So many people find that they see a doctor, they like them, and then all of a sudden they're gone and no one will tell you where they are. And that's because institutions look at patients as you're a patient of that institution and not of that doctor. And that's not how patients feel. So if your doctor leaves, they want to keep your business and they're not going to tell you where your doctor is going. And that really harms the primary care relationship. Michael Fine mentioned something very important at the beginning, talking about a longitudinal relationship. That doctor needs to follow you, because what happens at this stage of your life is going to influence the next stage and the third stage. And that doctor who's been there along the way is going to be the best one to hold your hand. But if someone keeps hopping in and out, you're not going to get high quality care. That's not what high quality care is. But because I've started my practice and I want to stay in my practice, and it's not so easy to break it down and move, I'm committed and invested to staying in this community. It also gives doctors smaller patient panels. So when I was in insurance-based medicine, my patient panel before I left was over 3,000 patients, which is astronomical. It took me a long time to find that information. I really had to fight for it. And what I found is that the average doctor in the insurance-based model probably shouldn't be going above 1,500. And here I was at more than double. No wonder I felt like I was drowning. And when I asked them to close my panel, somehow that was going to violate our insurance contracts. I really had no power to take better care of my patients. So was I really taking care of 3,000 patients? No. I don't even know if I had 3,000 appointments in the year, but that's how many patients were assigned to me. And I was supposed to juggle that workload. And it was just incredibly impossible. In direct primary care, the average panel that we talk about, panel meaning the amount of patients assigned to you, is around 500. So a fraction of that 3,000 I was caring for. So now in my practice, I have a much smaller patient panel. I spend much more time with them, and I'm much more flexible about the time that I spend with them. What's great about direct primary care is that with that direct model, direct means that the patient usually pays a periodic membership fee. So it might be a monthly membership fee or a quarterly membership fee. They don't use their insurance to access the office. So it's kind of their prepaid healthcare, right? So in that instance, I'm much more flexible about the way I deliver care. Compared to when I was an insurance-based fee-for-service model, we really only got paid for the patient being in front of us and doing a visit. And as we know, in this age of technology, not everything needs a visit. I have patients that say, hey, I'm depressed. Can we hop on a phone call? Or, hey, I've been having these thoughts about, or my toe's been hurting me. Can I send you a picture and we can handle it? And I'm willing to do that with my patients. I'm not going to force them to cross town just to go over something that we could have handled by text or phone. When I was in insurance-based practice, in order to get that type of care covered was almost impossible. You had to have the right codes and they got rejected, and you had to do all these little check boxes to meet the criteria of whether this telehealth visit was valid or not. And with this model, all of that goes out the window. My patients need care, and as long as it's appropriate, I will deliver it to them the way that it deserves to be delivered to them. So it's helped me be a much better doctor. It's been much more convenient for my patients. The time with my patients has made all the difference. So I'll back up a little bit with my story. The reason I got delved into direct primary care is because I worked for a large healthcare system in Atlanta that in 2022 ended up closing 2 hospitals and multiple outpatient primary care clinics because they were financially insolvent. So it was an incredible hit to the community. As you can tell, I was a rapidly burning out, if not already burnt. No, I was burned out. I was a burned out doctor at the time this was happening. I knew about direct primary care, and I didn't feel brave enough to jump into direct primary care. But when those systems closed and I was given a termination letter, not because my care was poor quality, but because they couldn't remain in the community anymore, I took that as a sign that we're not doing healthcare the right way. And if I was going to remain in medicine or remain a physician, I had to do it differently. And that's what launched me to start my direct primary care practice. So many of my patients who see me now were my patients in the former system. But you know what's amazing is I'm actually getting them healthier with less medication. That's what Patty talked about at the beginning. I have a patient who has been seeing me for years, and she has the typical things, the diabetes, the obesity, the hypertension that I've been managing for years. And I thought I was doing a pretty good job. And when I finally had the time to sit down and talk with her, I found out she wasn't sleeping well. She left the TV on all night. It was making her irritable throughout the day. And we made some critical behavioral changes, like getting her to sleep better, getting her to eat a little bit better. And this patient, I've been able to take off of most of her diabetes medication. She's lost over 50 pounds. She's more energetic than ever. And I've seen her for years, for years. But it wasn't until I changed the model was I able to really deliver high quality care to her that's really life changing and not just managing all of these illnesses. So that really concludes my story about how I got from fee for service to primary care, why I think direct primary care is so important, and why it's important to change the payment model for care, because we can unlock a lot of benefits that patients are looking for. Price transparency, you know what the price is up front, that's nowhere else in medicine. Longitudinal relationships with your physician, time with your physician, access to your physician in ways that aren't just a traditional office visit where you have to walk through the door every single time. So it affords so many benefits that we just have not had the pleasure of experiencing in the fee-for-service and insurance-based model that we've had. So if you ask me, I think one of the best pathways to get to primary care for all is through the direct primary care model. So that is my story. I hope you all have learned a little bit more about direct primary care, and I'm certainly happy to answer any questions that you have at this point.
Thank you so much, Michelle. I love your passion. I love hearing you talk about this. If you have a question for Michelle and you want to post it in the chat, we'll get to that in just a second. I really do believe together we can ensure everyone in the United States receives equitable health care and gets equitable health, regardless of where you live, whether you're up in Boston, in Atlanta, on the West Coast, how much you earn, or what community you come from, or what you look like. This is what we are trying to accomplish. And Michael, would you mind sharing how we're going to continue doing this work?
Thanks, Patty. As everybody knows, there's lots of stuff now happening around the country. We're hearing local work groups starting in Cleveland, in Alabama, in Florida, all sorts of different places. And it's a wonderful thing to see and hear. And it would be great if we could run on passion alone. But most of us know it takes more than that to make this kind of sustainable change. And to talk about that a little bit, I want to introduce my friend Larry Bauer, who started the FMEC, who really started the direct primary care movement, and has been a major force in primary care in the United States for a long time. Larry?
So one of the biggest challenges for us as a movement is funding the infrastructure of the movement, the staff that you need to organize activities and coordinate things. And we've struggled looking for funding sources. And I want to tell you about one that I think you can all succeed at. And so all of us are part of a social network that could help us to raise funds. We have friends, families, we have neighbors who we are connected with. And these people work for companies. Some of them are mid-size and large companies. And each one of those mid-size and large companies has what's called a development office. That is, they have money that the company sets aside for projects in the community that they want to support. I won't go into the details, but they actually make more money by giving money away. God bless America. So these companies are looking for projects either locally to them, or if they're a bigger company that's got regional offices or national office, they're looking for projects in the across the country. So if you know somebody in a mid-sized to large company, tell them about our purpose and ask if they will connect you with someone in the development arm of their company. You're asking for a name and an email address. You're not asking for money. If that person doesn't know the name of that person, they can look up in their own directory, because there will be in the directory a list of who's in charge of their development operations. When you get the name and email address, pass that information to Michael Fine, and we will approach that person. We will tell them about our organization, and we'll ask if they would be willing to provide financial support. The best way to start is to make a list of the organizations you're connected with. Your list is the key to success. Think of your family, friends, and neighbors, and think of where do they work? And you will find that some of them are working with these mid-sized and large companies. There are other sources of funding, but this is one that it's kind of like a no risk. You don't actually have to ask for money. I know a lot of people are uncomfortable doing that, but you can ask for help. Okay. Michael, I'm going to put my comments in the chat for everybody.
Thank you so much, Larry. I really appreciate that. You know, it is sometimes an uncomfortable thing thinking about asking for money, but it is part of what keeps our doors open. And speaking of money, Michelle, I see a lot of questions in the comments about patient. Before we come to that, I would recognize the fact that it's I've put our survey in the chat. If you haven't had a chance to complete that, we are going to go into our question and more open discussion time frame. And do know that we are having our next meeting on October 1st. So we'll still have a lot of information to give you in just a minute, but wanted to make sure you have that date of October 1st on your calendars for our next meeting, and have the ability to sign in. Please stay on. We will be going for another 30 minutes with some questions with Michelle and the board as well. But Michelle, can we go back to that question about pay structure? That seems to be one that comes up quite often. And in particular, you know, the general pay structure, and then how do we include the Medicaid, uninsured, undocumented within that as well?
Absolutely. And just before I proceed, I know in some places it's not okay to talk about pricing. Is it okay to discuss pricing here, or is that not allowed?
We're a nonprofit. I don't think there's any issues.
Okay,
Yeah.
gotcha. Just wanted to make
We're
sure. I
an-
know some.
We are an educational nonprofit.
I got you. You know, sometimes they talk about colluding and stuff, so I don't want to get in any trouble. But I did see several questions about pay structure. So to reiterate, direct primary care, the general structure of it is that people pay a periodic membership fee. Most practices do a monthly membership fee, and those fees can be as low as like $50 a month, sometimes as high as $300 a month. So there's a big range, which I think is great because it creates a market. So kind of allows people to start to vote with their dollars about where they want to go for their care, what kind of value they want to get out of it. Sometimes that fee might be annual, sometimes it might be quarterly, but it's some type of periodic membership fee. In that membership fee, every DPC is structured a little bit differently. The majority of them say that once you pay that membership fee, your care is essentially unlimited. So however many times you need to come in, you use the doctor. If you don't use the doctor, you still pay your fee, but it gives you access. So you know that when you call, it's not going to be months before you can get an appointment. You can get in same day and next day because you're part of a small group that can get you in very quickly. There are some practices that might charge a per visit fee on addition to their membership fee. And if you're going by the rules of DPC, at least the way it's written in some of the founding structures, that membership or that the office visit fee should not exceed the periodic fee. So let's say your membership fee was $100 a month, your visit shouldn't exceed that $100. So maybe visits are $50 a month. I don't see that structure happen as often, but that is a possibility. I want to say two more things about it. Many patients can often use things like their tax-free savings accounts to pay for this. The most appropriate ones are usually flexible spending and health reimbursement accounts. There's still some question about whether HSA can be used, or health savings accounts rather, can be used for DPC memberships. Many people do, but there is some tax law that makes it a little tricky. And then finally, we were just at Rosetta Fest, Michael Fine, and we talk about employers paying for DPC. So there is a market where employers are paying the membership fees on behalf of their employees to have access to a DPC practice. I will say a little side note here. Going to Rosetta Fest was interesting for me because part of me got a little funny about the idea of employers paying for DPC. I think it's to me, the beauty is every patient that's come to see me has made their choice as me as their doctor. I didn't show up on some card that they're like, oh, I guess this is who I'm assigned to. They kind of made a choice to choose me as their doctor. And I think the idea of including an employer can sometimes create that third party that direct primary care had tried to get rid of or had tried to separate from in the first place. But one thing I really love about direct primary care is that I want to make sure I phrase this correctly. I have a challenge with employer-based care, meaning that people have to be employed to get great care and employed at the right place. So how many people are afraid to leave a job, or if they get laid off, it compromises their whole healthcare situation. But if direct primary care is a benefit, almost like if your job gave you a gym membership benefit, even if you leave that job, the fees are still affordable enough that you can continue to be a member of that practice, even if your employer is not paying it on your behalf. That's not so true in today's current market, where you leave and Cobra is 3 or 4 times what you're used to paying. So even though sometimes I feel a little funny about employers being in that space, I think it does help make it a more fair and equitable space, just because there's more price transparency.
No, I think those are great points. And one of the other questions is, are there certain groups that we could partner with, for example, like the quality of care for patients with insurance provided by the government, right?
Yeah.
Gets a little complicated with some of those things, but I think your point of if it's more membership based, you can always keep going to that same gym as long as it stays affordable.
Right.
One other question that sort of is a little bit of a turn, but how do you, maybe at your practice or at other practices you've see the integration of nurse practitioners or other medical field employees?
Absolutely. I will answer that, but I do want to go back a little bit because you asked the second part of the question. It's come up a couple times in the chat about how do we care for people that can't afford membership fees? How do we care for the indigent? And I think it's really important to address that question. And I will say that direct primary care has worked in all different communities, again, because of that flexibility of the membership model. One thing I will say is that there are some challenges in taking care of the indigent and of taking care of people who can't really afford the fees. However, I don't want us to forget that the middle class who often can afford these fees are also being left behind in healthcare. So not to say that we shouldn't take care of everybody, but I feel like everybody jumps to the people who have the least amount of resources. And this may sound a bit controversial, but even as an insurance-based doctor, it was never my Medicaid patients that worried about hospital bills. It was never my Medicaid patients that worried about an ER bill. But it was always my single working mom that might be a secretary somewhere or a flight attendant, and maybe they have insurance, but every time they touch the doctor, they get hit with all of these fees that they don't understand and don't really have the power to fight. So I honestly feel like of everybody, the middle class is most being left behind because they may have these benefits, but every time they access them, it turns into a disaster that really can set them backwards. So I really feel like we need to start with the middle class because in many ways, they're starting to crowd out the resources that were really made for the poor and the indigent. So they're going to lower fee clinics and they're going to these places because the care is more affordable and more accessible because every time they go to their doctor, they get locked out. I have a patient, working gentleman, has a good insurance plan. I hate using that, but has good insurance, who has sickle cell and has had multiple crises. And I was like, your care is beyond what I can provide for you. I really need a hematologist to help take care of you. I sent him to a hematologist. He went to a hospital-based facility, so I should have known better. And he gets there, and before he can get through the door, it's $600 because of the hospital facility. So before he ever sees a doctor, he was going to be charged $600. And that man walked right out of that office because that was unaffordable. So when people talk about the high fees of DPC, I think we have to remember what we're combating. Now, the challenge is, I still think it's important for us to have a mechanism of insurance. But as I mentioned during my talk, insurance is covering too much. Imagine if we made insurance catastrophic. So I think the average family, and Michael Fine, you can correct me, or if the average person, I think, is paying what, $14,000 a year for insurance? Or I think right now we're paying at least $14,000 per American for their health care in general, about $14,000 for insurance. If we look at even some of the most expensive direct primary care practices, they're about $2,000 to $3,000 per year. So imagine if we carved out what people are paying in these astronomical insurance fees just to get one covered physical per year, and we gave that to direct primary care. How much could we reduce their ER utilization, which could be $2,000 a pop per visit? How much can we reduce their need to see a specialist because their primary care doctor doesn't have time to be with them? I love sharing stories because I think it illustrates the issue that we have. I have a patient that came to see me who has diabetes, and her A1C, I think, capped at about 9. So for those of you who don't speak diabetes, 9 is not good, but it's manageable. And so she's like, well, I got to see my endocrinologist. And I'm thinking, why? Like, I'm your primary care. We can handle that. But what she was used to is, like, she goes to primary care. They've got 7 minutes in the room. They diagnose and get her out the door to see a specialist. So we've made care so much more expensive because we have not allowed primary cares to practice in the breadth that they're able to practice in. I can easily manage an A1C of 9. I can easily manage thyroid disorders. I can easily manage hypertension. We don't have to have this team of specialists for things that are well within the realm of primary care. But our current structure and payment model does not support primary care doing what it does best. So I think we have to start with the middle class. And then after that, I think we can talk, no, not after that, you can do it concurrently, but talk about solutions for the poor and the indigent. I think another program that I'm not saying we have to replicate, but if we look at something like the food stamp program, that is not an insurance or a voucher program. People have food stamps there as a cash dollar assigned to that, and they use that money to access food. What if we had a similar program if there was a budget that was given to access primary care, and we use cash as the intermediary without using this third party that has all these strange requirements and all these different layers that make it very difficult to deliver care? So I do think there's a path to the indigent, but I think we have to talk about where we're having the biggest waste in healthcare, and I think that's affecting mostly the middle class.
Thank you so much, Michelle. I think that's, it's important to look at the whole scope of what we are trying to do and look at, where are the attackable areas.
Yeah.
So one of the things that speaking of attackable areas that we talk about, right, we've shifted some of the conversation to how do we give access to individuals. That's assuming we have a pipeline of, primary care available to them. Right? So we mentioned the NP and some of these other positions. How do they fit in, as well as, how do you see us being able to increase the pipeline so that we're not pulling people from practices to go into something like APC and then feel like we don't have enough doctors anyway? How are we pulling into smaller panels and decreasing access?
I think one of the scary things that Michael Fine says is that we're going to need to quadruple the workforce, and he's not lying, especially if we're going to have every doctor having a panel of 500 or less. And that's a reality. And so it's a high bar to get to, but we have to make primary care attractive again. It does not make any sense for a medical student to go into primary care. As much as we want them to do the right thing, it does not make sense to go in and get $300,000, $400,000, $500,000 in debt to get a job that's not going to help you pay that very quickly, but also one that's going to burn you out. It's a terrible idea. And I would be hesitant to tell people to do that. So we need to make primary care attractive. We need to stop the leak, because a lot of people are leaving primary care and leaving medicine in general because it's so dissatisfying. Like, it really is a hazard to your health because we are now the profession with the highest suicide rate. It is not safe to practice medicine the way that we are practicing, and we have to be real about that. So we have to make it a safe place again. We have to make it a rewarding place again. And I've never been more rewarded in my career than I have practicing direct primary care, because I can truly show up for my patients the way I show up for them. So that's one of the ways that we stop the leak. And I think if we make it more attractive from a job satisfaction standpoint and from a financial standpoint, we have to understand that many of us are motivated by being able to get great finances. So if you're going to put in all this work and go to med school and give up your 20s and 30s or whatever that is that you're not, that you're spending nights in hospitals, we do want to make it financially rewarding. Or at least take some of the edge away. Michael Fine talks about making sure we have scholarships for students so they're not leaving with astronomical amounts of debt or having debt persuade their decision. So we have to make it financially rewarding, or at least financially make sense. And when we do that, I think we're going to attract a lot more people to primary care. You also asked, I'm not dodging the question about using nurse practitioners, physician's assistants. And I'll be very honest, I was a huge skeptic of the nurse practitioner and physician assistant workforce. There are some challenges there. I still think we have to talk a lot about making sure that training is standard across the board. I think there are some programs that, quite frankly, should be shut down and are 100% acceptance rate, so they're really not screening anybody, and you can get these diplomas. I found out there's some programs you can go into without ever being an RN. You just need a bachelor's degree, and in 18 months, you can be prescribing medications to patients, and that's inherently unsafe. But one of the biggest reasons I was skeptical was that when I was in my fee-for-service life, not only did I have more patients than I could manage, but at that point they say, okay, well, why don't you bring on a nurse practitioner? Now we can extend your reach even more. So now I'd be supervising not only my 3,000 patients, but maybe their additional 1,000 patients, and watching over this person who I don't know what their skill level is, and loaning my license to do that. Incredibly risky and just not a good idea. In direct primary care, I actually think it's the safest place for us to use nurse practitioners and physician's assistants. Why? Because we can finally have a tight relationship between that physician and that nurse practitioner or that physician assistant. When you're seeing fewer patients a day, you can truly supervise. When I was in fee-for-service or insurance-based care, I think the threshold was I had to review only 10% of their charts, which meant 90% of the people that were seen by a nurse practitioner didn't even have their charts reviewed by a physician. And I think that's incredibly inappropriate. So that's not safe care. Like, it doesn't matter if you can get access if the care isn't safe and if it isn't high quality. But I have not brought on a nurse practitioner or a physician assistant yet, but I'm strongly considering it because I do think it can help me expand my services further, and I can develop a relationship with them to make sure that my patients have access to safe care. I would have never done that in the fee-for-service or insurance-based model. I just didn't think it was safe.
No, I think that those are really valid and good points that, as some of us, like, I'm not in the medical field. So like, even understanding what the different points and access, but you're right. As we are creating community, as we are creating those discussion groups and being able to, that's the number one thing I hear from my friends. I got into the doctor's office and they asked me if I had an x-ray. They're the ones that ordered it. How do they not know that we're
right?
And so there is a lot of that. I mean, people laugh about it, but like, concerning, you only know you've got those 5 to 7 minutes. As a recipient, you want to know that, you're looking at the charts that you asked for.
Exactly.
So I think these are really good and important things. So, we're setting a high bar. You've mentioned that a few times, both with, the numbers that we want to see, but also my mom is a professor, a nursing professor in the local UMass Dartmouth. And she talks about, like, do you want me to pass someone who like can't make it through pathophysiology? She's like, if you're not acing my class, I don't want you going to the next level. She's like, and if I have to be the bad guy to do that, like, okay, but I'm not taking you into the field that way. So I think there's a lot to be said there. So
absolutely.
I think that there's a lot of value in the diversity of care that we can provide through a lot of these programs. So I want to make sure that we hit some of these other questions that are going on. This is a
Mhm.
very active chat group today. I'm very
Yeah.
impressed with you guys.
I
So
do
trying
want to address or highlight one of the comments that was made actually by Pat Tokarts, who's also a new friend of mine. And he said somewhere in the chat that a lot of the DPC and concierge practices he gave some scholarships or gave free care to patients that couldn't afford it. And that is absolutely true. So I've actually run into that myself, where I have a patient who just lost his job, fell on hard times, and we worked out a much lower rate. So I think I'm not going to talk about what he's paying, but it's not very much at all. And I will say, if you're an insurance-based care, you can't make deals like that because it's insurance fraud. So if you're not charging them what the established insurance prices are, you could be brought up on charges because you're going outside of the contract. But when you have a private contract with your patient, you can say, you know what, your membership is free for 3 months. We'll work it out. Or your membership, we're gonna decrease the price for 50% for you or your family. Or we're gonna take on a scholarship to handle this many families in the community. So you can start to redistribute that care in a way that's very equitable, in a way that you do not have that flexibility when you're an insurance-based model.
Yep. I think that's a very valid point. There's a lot more comments if you want to take a quick look and just see if anything stands out to you. One thing that I want to mention to this group as a whole is it was really cool. Michelle and I started meeting a couple weeks ago and prep for this. Then somehow through all of those conversations found out that she and Michael and Pat were all going to be at the same conference together. And so through that communication, and one of my favorite things was on social media, I saw Michelle posted a picture with Pat, right? And that they had met and that they had had this really great discussion outside of this group. So if you are not following us yet on LinkedIn, if you're not following us yet on Facebook, social media, really these nights are great. We learn a ton together, but it's going to be in these conversations that happen. We tell you to put your information in the chat and to say to people like, hey, here's where I'm from. Go back, scroll, see who's, around the corner from you.
Yeah.
Go grab a cup of coffee, talk with them about how you can really enact some of that change. Go back if you didn't listen a few weeks ago. We had a great speaker who came in and talked about the power of two, right? Who really talked about it doesn't take when you story, it's not, 15 of my best friends decided we should start direct primary care practice together. It's her. She did it. And I'm sure you have community around you that made that decision, but it's not that you need permission from someone to go take action and make this happen. Really, we want you to go and use this as a launching point to really make these differences and then see success like what Michelle has seen and be inspired to go take that next step, no matter when you're starting this journey from.
And to get local work groups started in your own community. Patty, I wonder if this isn't a good opportunity to invite people to raise their hands and like have a little direct discussion. We've got a few minutes and that might be fun if somebody's got a question or comment to make directly. Does anybody?
I'd love that. If you want to go raise your hand or come off mute and I know Brian had raised his hand earlier. Go ahead.
There he is.
He found the button first.
I had raised my hand earlier and then my question was very much addressed in the last 20 minutes. So thank you. This has been a great presentation, Michelle. Thank you. This is really informative and really inspiring, which it's sometimes hard to combine those two things. So thank you for that. Somebody in the chat had asked about community health workers, and I'm really interested in that. I think there's been a fair amount in the press over the last few years about some places that use community health workers to improve their primary care system, like most high profile, I think, is Costa Rica, where people who are not physicians but are part of the community and are trained to know when to direct people to their primary care doctor or to other specialists, and to make sure they're still taking their meds and make sure they're eating healthy and blah, 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 and recognizing when somebody's unhealthy. Is that a part of DPC in general? And is that something you are doing or have considered doing?
Absolutely. So I will say with my experience, I don't think a lot of DPCs work with community health workers, and not because we don't want to. Let me first say that a lot of these practices are incredibly lean, right? So it's we get started the way I started, I was subleasing from another doctor. So she had this practice and I had one room and one exam room. So you have these very tiny spaces that you may be working out of because we're really getting healthcare down to the bare bones of really a doctor and the patient. And then some of these practices grow larger and might bring in more community resources. What I will say is most DPC doctors are highly engaged in their community, and I'm much more engaged in the community than I ever had been before. So for my practice, we do a lot of community activities. So we've done community nutrition webinars, we've done yoga in the park, we've done walk with a dog. We do all these different activities. So even if you're not a member of the practice, you get to engage and learn about healthy activities, learn about healthy behaviors from a physician that cares about the community. One of the, I don't know if this is a good or bad statistic, but I think many of us are aware that the mortality rate for Black Americans, there's a huge disparity. It's far below what white Americans experience in this country. But there's a study that just came out that showed, and I cannot remember who did it, I think I saw it through Kaiser News Network, that by having a Black physician in your community, whether or not you see that physician actually prolongs the life of members of the community. And that inspires me a lot. So even though I may not be seeing every single member of my community, when I get out and do yoga and they see their doctor doing yoga with them or walking in the park with them and talking about healthy food, it really promotes into the community. So I have not used community workers yet. I think when you have such a chaotic system like we have right now, you do need a lot more community health support to navigate it. But when your patient can really get right to you, not to say that a community health worker wouldn't benefit that relationship, but I think it's less important. So that's a risky thing to say, but I don't think it's as important as if you're dealing with it takes 3 months to get an appointment. You only get 7 minutes with your doctor and you really need somebody else to put this whole picture together for you. I've sat with my patients for an hour or two figuring things out. So I think there's a role, but I don't think it's as critical as when you make the system more streamlined or the relationship more direct. I saw Sarah put many DPC docs make house calls. So yes, I had never done that as a fee-for-service doctor. And I had a patient who unfortunately passed away, but she was in her final years. She was a elderly patient. She was dialysis. She was bedbound. It was non-ambulatory. So you can imagine how hard it is to get this patient to her primary care doctor. You know, they had to arrange ambulatory transport to get her to her dialysis sessions. But I was able to do house calls for her. You know, I didn't have to get insurance approval. I didn't have to go through all these mechanisms. She paid her membership fee. I was like, you know what? Let me come and do house calls. It's so much easier for you and your family for me to get to you than to you for you to come all the way to me. So you can just be so much more flexible with your community.
I
Thanks.
think Will.
Yeah, we have
Go
someone.
ahead.
I am trying to figure out how to say your name. Murdo?
Yeah, I'm unmuted. I put a thing in the chat about I've been doing DPC for 21 years, and Michelle, you kicked it right out of the park. That was amazing, your presentation. I'm thrilled with your passion and how well you said that. And again, I was never involved in organized medicine until I started my DPC practice back then, and I've been very engaged in organized medicine, community statewide, and trying to rebuild the passion and again, mentoring as many people as I can, from medical students, et cetera, on the power of DPC in the community. 21 years in, I find that, and I charge on the higher end of your benchmark numbers that you gave, and I tend to get people that nobody else will take care of. They've been sort of fired by all the other primary care practices. The specialists won't see them anymore. They're kind of frequent flyers in the ER. And sometimes those people can be very dependent. They can be very aggressive. They can be scary. My office staff is afraid of them. I do my best, but what do we do with those patients, the dead enders that really, are very challenging for us emotionally, and our teams are afraid of? What are our options for that population of people who are often high utilizers but need a lot of care?
Ooh, that's a good question. And I feel like I need to be deferring to you who has more experience than I do. But what's interesting, I'm glad you mentioned it. Like I didn't talk a lot about the fact that even though I'm still fairly novice in my DPC journey, I'm not a new physician, but I'm novice as a DPC. I speak with other physicians about direct primary care. And this summer, I spoke about boundaries in direct primary care and how healthy boundaries really help the relationship. And so I think we have to learn to negotiate those boundaries with patients. And I think you have to figure out like what is the demanding thing that's happening, and then try to develop, I guess, a strategy of how we manage that. So there are some people that might be overutilizers, right? So like they want to text all night. So for those of you that know, DPC sometimes I think can go a little too forward and say, we're here all the time, 24/7. That's a quick way to burn out. And I tell my patients, I'm available during business hours. After hours, if there's a true emergency, you call. You can send a text message, but you're going to get an auto reply that says, Dr. Cooke is out of the office, and she'll respond to you during the next business day, because I can't stay up all night taking patient calls. It's going to burn me out. Now, if that patient is calling every night, it's very unlikely there's an emergency every single night, right? And so if there's a true emergency, okay, this is emergency. I'm glad you called me. Let's handle it. But if you're calling me because you're upset because the pharmacy didn't have your medication and it's not urgent, or you're upset because, I don't know, something that's not urgent, you can start to use that point to educate the patient. I want to be available for you, but this is not an urgent call, right? And if we're calling on a non-urgent basis repeatedly, this could compromise your membership. I want to continue to take care of you, but if we're using the resources of the office inappropriately, we're not going to be able to continue this relationship because I can't serve you appropriately. And you're not trying to scare patients, but I think it helps them understand, if I keep using this route, I'm going to burn out my doctor. I'm going to burn out the situation that really wants to care for me. So I have to do a lot of boundary resetting with some of my patients who might be using the service inappropriately. I have never quite had somebody that I felt was aggressive. So I haven't quite been in that situation yet. I feel like most of them are very gracious when they come to the office. I think if there's a sense of aggression, you have to listen to your gut. And you may need to escalate that, right? I mean, I'm not trying to say bad things, but we've seen some terrible things happen at doctors' offices where people want to get violent, and I don't want to ever see that happen to you. So I don't think you need to go out of your way to serve somebody that you think might actually be violent towards you. I think that needs to involve authorities. But with patients who are simply overutilizing or really taxing the resources of the office, I think it's time to talk about boundaries, come up with a different plan. Maybe you see them more regularly to say, okay, you're calling the office all the time. Let's give you a standing appointment every Tuesday at 11 o'clock as your slot, so that we can work out what's going on with you. So that way, I'm saving that time for you to deal with what we have going on until things calm down. What I found in my DPC is that when people first get on board, they almost don't believe that they can access me that easily. And so they try me a lot. They're like, oh my gosh, will she really respond to my text? Will she really respond to my portal message? So I get this big heap of utilization. And then they calm down because they know I'm there, right? They're so used to, like, I call the office 12 times and can't get my answer, or I've called and I've been in the voicemail, and the only way I can get a doctor on the phone is if I call after hours. And I think you have to kind of untrain people from that behavior, which what they learned how to do because the system was so bad.
Very discussion tonight, guys. We're going a little off script, but I love that for the discussion especially. So thank you, Michelle, you for presenting to us tonight. Thank you for everyone staying, continuing the discussion that we had today. Remember our next meeting in October. I just dropped the website in where you can register for our next conversation. If you are there and volunteer or donate, get involved, follow us on social media. This is for people and not for profit, right? Primary care for all Americans. Michael?
Thanks, Patty. What a great presentation. And what a great discussion. I was really interested in the folks who wanted to remind us of the value of community health centers and the work they do, as well as the work of DPC. And I think the thing that we keep learning over and over again is that the solution to the primary care crisis and the healthcare mess is going to happen community by community, with each community figuring out the different pieces to put into play to make sure everybody gets taken care of. And we're going to, community health centers are amazing places. They have some limits just on the number of folks they have and the number of folks they can take care of, at least until we get them better resources than they have already. I want to finish out with a quick story. As I was flying back from the Rosetta Fest, I sat down next to an old friend who's a very senior health policy guy and public health guy, who was flying back with me. He had been at the Congressional Budget Office for a hearing, and he told me about this amazing thing that Kaiser was doing. They had shown off that they had gotten artificial intelligence to be able to record sessions and create notes with all the billing that needs to happen, even though it's Kaiser, so they don't really do billing. But anyway, and that they were going to save 2 hours per physician per day. Wasn't that wonderful? And I thought, yeah, that's kind of cool. Maybe that will help us with the workforce. And then he looked at me and said, but what's probably really going to happen is as soon as they save the 2 hours, people will slam each primary care person with more and more work to do in another way because they're employed and they just don't have the ability to push back. So that, I think, is the reminder that when we've got somebody else in charge of this healthcare thing, when it's not communities and individuals taking responsibility for it, when we're letting somebody else do it, bad things happen. But when communities do it for themselves, we can make a difference. We can make this revolution happen. And it basically means that you are all revolutionaries by the work you do every day. Remembering that if we don't step up, we're going to get stepped on. So this is the opportunity to change it. The work we're all doing together gives us the fuel to make this engine run. Again, you hear me say this each time. This isn't a Democratic thing. This isn't a Republican thing. This isn't a political thing at all. This is an American thing. And it's what we can do and have done in the past when we build social movements, which is we fix problems and at the same time we reinvigorate democracy. What a great opportunity to do this together. Thank you again, Michelle. Thank you to the whole team that puts this together. Let's keep doing this together and make this thing fly. Thanks, everybody.
Thank you.